John here from Anatomy Bootcamp, and in this video we're going to be discussing the cranial nerves, their functions, and functional deficits that would be observed if these nerves were damaged. First off, we're going to start off with a little case study. In this case, we have a 42-year-old patient who's complaining of blurriness in their peripheral vision. After performing blood work, you notice that their GH and IGF-1 levels are through the roof. You then order an MRI to confirm your diagnosis. So we're going to be circling back to this case after we've gone to a couple of cranial nerves to see if we can diagnose what is going on here. So we have a couple learning outcomes. By the end of this lesson, you should be able to identify and name all 12 cranial nerves, list their functions, as well as diagnose cranial nerve damage based on symptoms. So first off, we're just going to start off with a blanket overview of the cranial nerves. We have 12 of them, and they're going to be emerging off of the ventral surface, or this inferior surface of the brain. And they're labeled 1 through 12 in Roman numerals based on their positioning. So here would be the rostral end, here would be the caudal. So rostrally, we're going to have 1, and then we're going to move down, and at the caudalmost aspect, we're going to have 12 right here. And all these structures are going to go on to innervate different structures of the head and the neck, apart from the vagus nerve. The vagus nerve actually has some nerve fibers which travel down into the thorax and abdomen to perform some functioning down there. And the cranial nerves can be broken up based on where they're emerging from the brain. So this is how I learned it. We have 2, which are going to be emerging directly off of the brain tissue. We're then going to have 10, which emerge from the brainstem. These can then be further broken down. We will have 2, which emerge from the midbrain, 1, which emerges from the pons, and then we're going to have 7, which emerge from the medulla, and they all start medial superior and work their way down laterally and inferiorly. So you'd have 6, 7, 8, 9, 10, 11, and then 12 is going to be a special case where it emerges from the center of the medulla. So just a quick overview of everything again. We have the olfactory nerve emerging directly off the brain tissue. We have the optic nerve with the optic chiasm and optic tracts are emerging from the brain tissue as well. We're going to have the ocular motor nerve emerging from the anterior or the ventral portion of the midbrain. We'll have the trochlear nerve emerging from the posterior portion of the midbrain. The trigeminal nerve will emerge from the pons. We then have the abducens, which is going to emerge at that pontomedullary junction, along with the facial nerve and vestibulocochlear nerve. So this is 6, 7, 8. We then have the glossopharyngeal nerve, which is cranial nerve 9, the vagus nerve, which is cranial nerve 10. Our accessory, or spinal accessory, is cranial nerve 11, and this has inputs from C1 to C5 and comes back up into the brain. And then finally, we have cranial nerve 12, which is the hypoglossal nerve, which is going to emerge off the anteriormost portion of the medulla. And that is coming from between the pyramid and the olive. So first, we'll start off with the olfactory nerve going into its pathway and its function. So the olfactory nerves are actually going to be these nerves found in the nasal cavity right here. And they're embedded in the wall or in that nasal mucosa. And these are the axons of the olfactory nerves. The olfactory cell bodies are actually found up in here in the bulb. So these axons will travel through this bone right here. This is the ethmoid bone. So this portion where the bulb or the olfactory bulb sits on, this is the cribriform plate of the ethmoid bone, and it has little holes in it where these olfactory nerves will send their fibers through. So odorants that are picked up in the nasal mucosa are transmitted through these olfactory nerves to the olfactory bulb, which will then send it down the olfactory tract to the primary olfactory cortex, where it will be interpreted and perceived. So the main function of these fibers is to smell. And if these fibers are damaged, so let's say you had an ethmoid bone fracture, or you had whiplash and you had some axonal shearing, which means that your olfactory bulb ripped away from this bone and you damaged these nerves, you would have something known as anosmia, which is a loss of smell. So if these nerves are damaged, if all these nerves are damaged, we're going to lose our sense of smell. So next up, we have cranial nerve 2, or the optic nerve, and we're just going to break this down because it has multiple components. So I'm just going to do a little overview, and then we'll get into the visual pathways. So first, light from the external world is going to come in, and it's going to hit this portion at the back of the eye, known as the retina. And the retina is broken down into two parts. We have our temporal retina, which is going to be on the lateral side, close to the temporal. And we have the nasal retina, which is going to be on the medial side or close to the nose or the midline. So light's going to come in and it's going to hit the nasal retina and the temporal retina. And you can see all this information is going to create a signal which is going to travel down the structure right here. This is the optic nerve, and it's carrying both information from the nasal retina and the temporal retina. So the temporal retina information is going to come down and it's going to stay on the same side, whereas the nasal retina information is going to come over. It's going to cross over to the other side, and this happens on both sides. And it crosses over at this point right here, known as the optic chiasm. So at this optic chiasm, temporal retina information is going to stay on its ipsilateral side, and nasal retina information is going to cross over to its contralateral side. Now, once we make it past this optic chiasm region, now we're going to be in the optic tract region. So this information is going to be carried down the optic tract, and it's going to end up at the lateral geniculate nucleus, which is part of the thalamus. From there, it is sorted and sent to the primary visual cortex. And it's important to note that these optic nerves pass through the optic canal on the cranial vault floor in order to gain access to that orbital cavity. And another thing that we need to highlight is where the optic chiasm sits. So if you remember from the lesson on the diencephalon, that optic chiasm is actually going to be the anterior-inferior boundary of our hypothalamic triangle right here. So right here, that's that optic chiasm, and it's going to sit just anterior to the infundibulum right here. And if you remember, the infundibulum is what the pituitary gland attaches to. So we have the infundibulum and the pituitary gland just posterior and inferior to that optic chiasm. And of course, cranial nerve 2, or the optic nerve, this is going to be responsible for our vision. So anything that we see in the external world is processed through this cranial nerve. So now let's break down the visual pathway. So you can see our temporal and our nasal retinas are highlighted in different colors, and it switches on the opposite side. So if we color in the visual field, our temporal retina is collecting light information from right here. So this is actually the nasal visual field, and our nasal retina is collecting light from over here, and this is the temporal visual field. So you can see the nasal visual field processed by the temporal retina is red here, and the temporal visual field processed by the nasal retina is red here. And these red fibers are all this visual information from the left side. Well, this is going to cross over to the contralateral side. So our nasal retina, remember, it's going to cross over at that optic chiasm right here, and it's going to join in our right optic tract along with the temporal retina, which stays ipsilateral. So we have contralateral and ipsilateral, and this optic tract is now processing all this contralateral information. So this is the right optic tract, but it's processing left visual field information. And the same is true on the other side. So we have our temporal retina picking up this nasal visual field information, and our nasal retina picking up this temporal visual field information. And in real life, these two nasal visual field areas, these actually overlap, and this is known as the binocular visual field. So these can almost be counted as one because of their overlap. So if we follow this down, all this binocular information, this is going to be processed by the temporal retinas, and these temporal retinas stay on the same side. All this peripheral information, well, this is processed by that nasal retina, and that nasal retina on either side, those cross over at that optic chiasm. So now let's take a look at what happens when we have an optic nerve lesion, an optic chiasm lesion, and an optic tract lesion. So in this case, we have an optic nerve lesion right here, and this is the left optic nerve. So all this visual field is not going to be able to be processed. So we're only going to be able to process information from our right eye, because if we remember, that nasal retina crosses over and that temporal retina stays on the same side, but we're not getting any information from this left eye because it has been lesioned. So let's color this in. So damage to the left optic nerve will cause loss in the left vision. So optic nerve damage causes monocular blindness or ipsilateral vision loss. Now we have damage to our optic chiasm, and this is going to cause loss of vision in both of our peripheral visual fields, but that binocular visual field, well, that's still going to be intact. And if we look at this, the nasal retina, which picks up this peripheral visual field, well, these cross over at that optic chiasm. So if we have a lesion right here, this visual information is not able to cross over. Only the ipsilateral information is able to reach the lateral geniculate nucleus and then go to that primary visual cortex. So this temporal retina, which stays ipsilateral, well, this is picking up that visual information from our binocular visual field. And these two areas, they overlap. So it's like we only have a circle of direct focal vision. All of our peripheral vision is going to be blurred or blind because depending on the severity of the lesion, we're not going to have information from that peripheral vision crossing over and processed in that primary visual cortex. And optic chiasm damage leads to something known as bitemporal hemianopia, or bilateral peripheral vision loss. Because again, we're losing our peripheral vision. So now let's take a look at optic tract damage. So you can see we have a lesion right here on our optic tract. And if you think about it, this can cause loss of visual information from the temporal retina of our left eye and the nasal retina of our right eye. So the nasal retina crosses over, the temporal retina stays on the same side. But this information is coming from the nasal visual field and the temporal visual field. So both of these areas are not processing information. And both of these retina areas are processing the nasal visual retina on the left side and the temporal visual retina on the right side. So we're going to have blindness in these two areas. So it's going to look something like this because our nasal retina from our left eye still able to cross over to the optic tract. Our temporal retina from our right eye still able to reach the right optic tract and is processed in that right lateral geniculate nucleus. So all this visual information is able to be processed. Optic tract damage on our left side is going to lead to right homonymous hemianopia, or contralateral visual field loss. Now coming back to our 42-year-old patient with blurriness in their peripheral vision, this indicates that their nasal retina is not processing that information from those temporal visual fields. So if you think back to those cases, it must have to do something in the optic chiasm. And based on our blood work, with high levels of growth hormone and insulin-like growth factor, this indicates that there might be something wrong with the pituitary gland. So we order an MRI and you can see right here, this massive tumor sitting right at the base of the brain. This is a pituitary adenoma. And if you remember, our pituitary gland is going to sit right below that optic chiasm. So if this grows, this is going to compress our optic chiasm. It's going to prevent that crossover of information from our nasal retina to be processed in our primary visual cortex. So that's why you're going to have blurriness in your peripheral field, but your bifocal area, that's still going to be intact. And you can see on this diagram, here's a pituitary adenoma growing on the base or the anterior pituitary gland. It's going to increase the release of GH, which is going to increase the release of IGF-1. So if we have these high levels in the blood, it's an indication that something is going wrong here. And so I hope that makes sense. We're going to move on to the other cranial nerves now. So next up, we have the ocular motor nerve, and this is going to be our first cranial nerve off of our midbrain region. So here's that midbrain region. Here's the optic or the visual pathway system, which we just talked about. So the optic nerves and the optic chiasm. This is always a good landmark. Always identify this X just to orientate yourself of where you're at. Just inferior to that, here's where we're going to have these big cerebral peduncles, which we'll talk about in other lessons. But this designates that this is the midbrain region. Coming medial to these cerebral peduncles, we're going to have these two little nerves right here. These are going to be our ocular motor nerves, cranial nerves 3. So these are going to emerge from the ventral midbrain, and they're going to travel anteriorly and enter the orbital cavity right here through a slit known as the superior orbital fissure, as you can see right here. And this superior orbital fissure is going to be a common entrance point for a lot of the cranial nerves, which are going to control the muscles of the eye, not the retina via this optic nerve. This travels through the optic canal, but nerves that control the muscles of the eye. So you can see our ocular motor nerve, it's going to go on to control the medial, inferior, and superior recti muscles, as well as the inferior oblique and the levator palpebrae muscle. So the levator palpebrae muscle, that is going to be controlling the eyelid. So that's kind of external. Moving to the extraocular eye muscles, the ones that actually control the movement of the eye. We have the superior rectus right here, the middle rectus right here, and the inferior rectus right here, along with the inferior oblique. And you can see we have the inferior branch of ocular motor coming and innervating these ones, and then the superior branch of ocular motor innervating that superior rectus muscle. Now, the ocular motor also carries parasympathetic innervation to the ciliary ganglion, which will then enter the eye, and this controls pupillary constriction and lens focusing. So now let's talk about the next cranial nerve, which controls another extraocular eye muscle, and that is going to be the trochlear nerve. And coming to our midbrain region, here's our midbrain with our cerebral peduncles. We said the ocular motor is going to emerge ventral to the midbrain, just medial to the cerebral peduncles. The trochlear nerve right here is going to emerge laterally, and it comes laterally kind of out of the shadows because it originates on the dorsal aspect of the midbrain. And this is the only cranial nerve which arises from the dorsal aspect of the brainstem or midbrain. So it's very distinctive in that sense. And it comes around and it wraps around these cerebral peduncles. And then it comes through that superior orbital fissure again, except this time it's going to be innervating our superior oblique muscle. So you can see here's that trochlear nerve. Here's that superior oblique muscle. And the way that the oblique muscles are situated in the eye, when this muscle contracts, it's going to pull the eye to look inferiorly and laterally. And we'll take a better look at this in a couple slides. But the superior oblique muscle rotates the eye inferior laterally or downwards and outwards. So it allows me to look down there. So the superior oblique muscle allows to rotate the eye inferior and laterally or downwards and outwards. So it allows me to look down in that direction right there. Moving on to the next cranial nerve, which controls the last extraocular eye muscle. This is going to be the abducens nerve. And you can see we've jumped to cranial nerve 6. So cranial nerve 5 is the trigeminal nerve, which we'll come back to. So the ocular motor nerve is cranial nerve 3. The trochlear nerve is cranial nerve 4. Trigeminal nerve is actually cranial nerve 5. Abducens nerve is cranial nerve 6. So we skipped number 5. And we're just going to talk about abducens nerve first while we're in this eye region right here. And then we're going to come back to the trigeminal nerve. So this abducens nerve right here, this is going to arise from a region known as the pontomedullary junction. And the pontomedullary junction gets its name because it's the junction between the pons and the medulla right here. And you can see when we're starting medial towards that midline, it's going to be the most medial cranial nerve coming off that pontomedullary junction. We have all these ones over here as well. So this is the abducens nerve. Like the other nerves that control extraocular eye muscles, passes through that superior orbital fissure, and then it goes on to innervate this lateral rectus muscle right here. So the trochlear nerve and the abducens nerve are the same in a sense in that they only innervate one extraocular eye muscle. What the lateral rectus does is it allows us to abduct or look away. So look towards the lateral direction with our eyeballs. So now let's just do a quick overview of all the muscles of the eye that we've just discussed. So we have the lateral rectus, which is controlled by cranial nerve 6. And if you remember what its function is going to be, lateral, it's going to pull the eye laterally. So it's going to abduct the eye to look outwards. And then we have the medial rectus, which does the opposite. And this, of course, is controlled by cranial nerve 3. So here we have all the muscles. Here we have all the cranial nerves. I'm just going to get these highlighted. So we have the medial and lateral rectus muscles. So next up, we have the superior and inferior recti, which are both controlled by the ocular motor nerve. We're going to take a look at this diagram right here. So notice how the eye is directed forward. Our superior rectus muscle, as well as the inferior rectus muscle, they're coming in at an angle. So when we get a force of contraction pulling backwards, this is going to, in this case, the superior rectus muscle, this is going to elevate the eye, so it's going to look upwards. It's also going to make it turn medially. So it's going to rotate it medially, and it's going to look upwards. So it performs a medial and upward directing look, as you can see with my right eye right here. So I'm looking up and towards the midline. The inferior rectus does the same thing, except it looks down and medially. So it looks down and towards the nose or towards the midline. Next up, we have our inferior oblique and our superior oblique muscle. So if you remember our inferior oblique, that again is going to be controlled by that cranial nerve 3, the ocular motor nerve, and our trochlear nerve is going to be controlling the superior oblique muscle. So again, looking at this diagram, here's that superior oblique muscle. The inferior has a similar layout, and it's attached via this trochlear sling right here. So it comes anteriorly, slings around here, and then it moves posteriorly. And when this contracts, it's going to cause the eye to rotate this way. And in this case, with the superior oblique muscle, it will cause the eye to look inferiorly as well. So the superior oblique muscle, which is controlled by the trochlear nerve, well, this is going to move the eye inferiorly and laterally, so downwards and outwards. And the inferior oblique muscle, this is going to cause the eye to move laterally as well, but it's going to elevate it, so it's going to cause it to look outwards and upwards. So now let's just clean this slide up a little bit. My writing's not the neatest. Now, one way to remember all the muscles and the cranial nerves which innervate them is a little mnemonic, SO4 LR6 AO3. So let's write that out. We got SO4, or superior oblique cranial nerve 4, LR6, lateral rectus cranial nerve 6, the abducens, and then AO3. So all others are innervated by cranial nerve 3. So SO4 LR6 AO3. All right, so now we have another case which is going to help us learn the next cranial nerves. So in this case, we have a patient with a droopy left side of the face who cannot control facial expression on that side. However, their chewing on the left side seems to be fully intact. So what is going on here? Well, this is going to be involving a couple of cranial nerves, so let's break these down. So first, we're going to start off with the trigeminal nerve. And if you remember, this is the nerve that we skipped. So this is cranial nerve 5. We skipped over cranial nerve 5 to discuss the abducens nerve with the rest of the cranial nerves that talk about the extraocular eye muscles. This trigeminal nerve right here, cranial nerve 5, this is more involved in sensory of the face and a little bit of motor. So looking at where this emerges off the brain, this is going to come directly off the pons. So you can see it's going to be this thick nerve right here. And when this emerges, it's going to divide into 3 divisions. We're going to have the ophthalmic division, the maxillary division, and the mandibular division. The ophthalmic travels through the superior orbital foramen, maxillary through the foramen rotundum, and the mandibular through the foramen ovale. And they're going to provide sensory to this ophthalmic region right here, this maxillary region right here, and this mandibular region right here. So all the sensory of the face is controlled by our trigeminal nerve right here. It also has a little bit of motor function. So our mandibular division, as it comes down, it's going to give off branches to these muscles right here, the masseter, the temporalis, the medial and lateral pterygoids. And if you remember from head and neck anatomy, these are going to be our muscles of mastication. So our muscles of mastication, of course, are innervated by the motor branch of that trigeminal nerve. So if we had damage to the mandibular division of the trigeminal nerve, we would lose both sensation down here as well as our ability to chew on that side. So moving on to the next cranial nerve, we've got cranial nerve 7. We're skipping over 6 because we already covered it. Cranial nerve 7, this is going to be that facial nerve. So that facial nerve is going to originate from the pontomedullary junction. So remember, cranial nerve 6, or abducens nerve, started closest to the midline. So this is the most medial cranial nerve starting at the medulla. If we go one over, so cranial nerve 6, here's 7. This is going to be that facial nerve. So this arises at that pontomedullary junction as well. And it's going to travel through the internal acoustic meatus and exit out of the stylomastoid foramen. So you'd have a styloid process right here, a mastoid right here. It's going to come out of the stylomastoid foramen. And if you remember from head and neck, here is where you're going to have that parotid gland. So it's going to duck in behind that parotid gland. And when it's in there, it's going to divide into 5 major branches. We're going to have our temporal branches, zygomatic branches, our buccal branches, our mandibular, and our cervical branches. And all 5 of these branches are going to provide motor innervation to the muscles of facial expression. So we have muscles which control the mouth, muscles which control the eyes, muscles which control the forehead. So one mnemonic that helps me remember all the branches of the facial nerve which provide motor innervation to the muscles of facial expression is 2 Zanzibar By Motor Car. So 2, this is going to be those temporal branches. Zanzibar, this is going to be our zygomatic branches. By, these are going to be our buccal branches. Motor, this is going to be our mandibular branches. And then, of course, we have car, which is going to be our cervical branches. Now, the facial nerve isn't just responsible for providing motor to the muscles of facial expression. It also has a special sensory function. It provides taste to the anterior 2/3 of the tongue. And if you remember which branch of the facial nerve this is, it is the chorda tympani. That's right. That chorda tympani joins with the lingual nerve, and it provides taste sensation to the anterior 2/3 of the tongue. It also carries parasympathetic innervation to the lacrimal gland in the eye. So this allows us to produce tears, to the sublingual gland and the submandibular gland within the oral cavity right here, which allows you to produce saliva. So if we had damage to our facial nerve, if we had specific damage to any of these branches, we would have localized deficits. If we had damage like back here to the root of the branch, we would have damage to all these structures. The special sensory and the parasympathetic structures, these take an alternative pathway. They don't travel along this branch right here. They actually go inwards as these ones come outwards. So if we had a damage right here, let's say if we had a swollen parotid gland, it's compressing those facial nerves. These are going to become weakened, but the nerves which are carrying special sensory and parasympathetic, those are going to be untouched because those are already inside of the facial structure. So next we got cranial nerve 8. This is the vestibulocochlear nerve. This again is going to arise just lateral to our facial nerve. So here was that cranial nerve 7, our facial nerve. Here's cranial nerve 8, our vestibulocochlear nerve. So this is just one over. And this cranial nerve is also going to go through that internal acoustic meatus, except now it's going to travel to this inner ear portion. It's going to have a cochlear branch, which is going to be involved in hearing. So it innervates the cochlea. So any sound vibration that comes in is interpreted through this cochlear branch. And it also has a vestibular branch, which is going to go to the vestibular apparatus, which is going to allow for balance and equilibrium in that sort of perception. So it's two function: cochlear, hearing, vestibular, balance. So damage to this whole nerve, this will cause loss of hearing as well as equilibrium difficulties. Damage to these individual branches will have localized and individual deficits. So now coming back to our patient with the droopy face, we know that the facial nerve is controlling those muscles of facial expression. And this patient is having difficulty moving his left side of his face. So that means that the facial nerve on this side has been damaged somehow, and he can't control those muscles of facial expression and know how his muscles of mastication are still intact because he's still able to chew. So that means that the mandibular branch of the trigeminal nerve is still fully intact and is allowing him to chew. So we've localized it to left facial nerve damage. All right, we are starting off with another case study. This one is a big one. This time we have a patient presenting with difficulty balancing, facial muscle weakness, worsening hoarseness, so they have like a raspy voice, difficulty swallowing, reduction in taste sensation. They have decreased salivation in their parotid gland. They're having difficulty turning their head to the right, as well as atrophy of the left trapezius muscle and SCM muscles. So you order an x-ray and it reveals a huge tumor. This guy right here compressing the brainstem. I mean, this is obvious as day. This hyperintense region on both scans. This is a tumor. Here's our brainstem right here. This is the base of the cerebral cortex. And on this view, here's our brainstem. So your job is to diagnose which cranial nerves are being affected and causing which symptoms. So with that out of the way, let's jump back into our cranial nerve discussion. We got our glossopharyngeal nerve. This is cranial nerve 9. This is going to be originating from the medulla as well. So we had 6, 7, 8. Right beside, we're going to have cranial nerve 9, our glossopharyngeal nerve. This is going to pass out of the jugular foramen, and it's going to head towards the pharynx and tongue. So this has a bunch of functions. I've just simplified them. It does motor to the stylopharyngeus muscle, parasympathetic to the parotid gland, so this increases saliva production. This is going to do sensory to the posterior 1/3 of the tongue, as well as the pharyngeal mucosa. And it also measures blood pressure at the carotid sinus and body. So at that point where our common carotid divides into the internal and external branches, we have that carotid body, and this carotid body measures blood pressure and has chemoreceptors and baroreceptors, and all that information is traveling through the glossopharyngeal nerve. And then finally, it's the last special sensory function. It's also going to do taste to that posterior 1/3 of the tongue. So it does general sensory as well as taste to that posterior 1/3 of the tongue. So that's going to be this region back here. Next, we have cranial nerve 10. This is going to be that vagus nerve. Right here was that glossopharyngeal. One down. That's our vagus nerve, cranial nerve 10. Originates from medulla. Also travels through the jugular foramen with that glossopharyngeal nerve. It's going to send some branches to the larynx, as well as travel down the neck and enter into the thorax and abdomen, but also send a recurrent branch. And this is going to provide motor innervation to the pharynx and larynx. So this allows for swallowing and speech production. So these little branches right here, these are going to allow you to swallow. These ones going into the larynx and the recurrent laryngeal, these are going to allow you to produce speech. So this is involved in swallowing and speech production. And it also does sensory to the mucosa of the pharynx. So these also do sensory back here. Furthermore, it also does special sensory. So it does taste to the epiglottis area. So that's all the way at the back of the oral cavity between the oropharynx and the laryngopharynx. And also does parasympathetic motor impulses to the heart, lungs, abdominal viscera. And this regulates heart rate and digestion. So this is involuntary control. You don't need to think about how your heart is beating. That's all parasympathetic innervation. And that's all coming from that vagus nerve. So this controls heart rate, digestion, all those internal visceral functions, which we don't have time to think about. They just need to perform. And it also does general sensation to those areas as well. So continuing on, we're at cranial nerve 11 now, which is our spinal accessory nerve. So we had cranial nerve 6, 7, 8, 9, 10 right here. Now we have this guy. This is 11. And this one is very distinctive because of all these branches which are contributing to it. So it originates from the ventral rootlets of C5 to C1. It's going to pass upwards. It's going to enter through this opening at the base of the skull. That's going to be that foramen magnum where the brainstem and spinal cord pass through. So it's going to re-enter up through there. It's going to join with our glossopharyngeal and our vagus nerve. So our glossopharyngeal, vagus, and spinal accessory, these all pass out of the jugular foramen. So these three all travel through that foramen. And this is going to innervate muscles, specifically the SCM muscle, the sternocleidomastoid, and the trapezius muscle. And these allow to turn and flex and extend the neck. So damage to this nerve would be easily observed because we wouldn't be able to, let's say, flex or turn the neck on the side contralateral of the nerve damage. And now finally we're on our last cranial nerve 12. This is the hypoglossal nerve. This is going to originate closer to the midline of the medulla. So we worked our way down and out. Now we're going to come back towards the center. So between this structure right here, this is the pyramid of the medulla, and this structure back here, which is the olive, right here would be the olive of the medulla, we're going to have these nerve fibers coming out. This is going to be cranial nerve 12. This is going to be the hypoglossal nerve. This travels through the hypoglossal canal, and it's going to make its way down into the oral cavity, where it's going to innervate our extrinsic and intrinsic tongue muscles. And you can see here we have a normal tongue. So when a patient is asked to stick out their tongue, it comes out direct and straight. If the patient had damage to their hypoglossal nerve, in this case, this patient has left hypoglossal nerve lesion, and we know the lesion is on the left side because the tongue starts to protrude towards the side of the lesion, because this side is so weak that it can't counterbalance the strength of the right side. So the right side will overcompensate and push the tongue this way. So this would be left hypoglossal nerve lesion on this side. So coming back to our case study with all those symptoms, we have which cranial nerve is responsible for facial muscle weakness and reduction in taste sensation, specifically the anterior 2/3. We talked about this earlier in the lesson. This is going to be cranial nerve 7, or facial nerve. And then we have difficulties in balancing. Well, this is going to be that vestibulocochlear nerve, specifically that vestibular branch, which is involved in equilibrium. This is cranial nerve 8. Now we also have reduction in taste sensation in the posterior 1/3 of the tongue, as well as parotid gland salivation reduction. So we can't produce as much saliva from our parotid gland. If you remember, this is involved for cranial nerve 9. That is the glossopharyngeal nerve. And then the hoarseness, difficulty swallowing, and reduction in taste sensation in the epiglottis area. Well, this is that vagus nerve. And then finally, to explain our difficulties in turning the head to the right, as well as atrophy of the trapezius and SCM muscles, that is going to be explained by involvement of cranial nerve 11. And if you remember, all these cranial nerves are coming off of the brainstem around this area. They're all closely associated. So when we have a tumor this big, and in this case, we have an acoustic neuroma that has just overexpanded this area, it's going to affect a number of different cranial nerves. And mind you, this is a very dramatic case. Hopefully by the time it gets this large, you'll notice some major deficits and go seek treatment before then. But this is just an example of how bad things could get and how many cranial nerves could get involved.